Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Okay, guys. So I welcome one and all for the class tonight, and we are going to be discussing the paper number 3 now, which is May 24. And this is obviously a gynae part, but like I always say, there's a considerable overlap in the papers, guys. So please make sure that all of you know this thing, and you are not taken aback by any obstetric questions, recent advanced questions, or basic questions. Suppose they're interspersed in the other question paper. So the first, very, very easy. I found this question paper to be very, very basic and very easy. I don't think anybody's going to fail this kind of a question paper, but let's start. So first of all, clinical presentation of hyperprolactinemia. Quickly now in the chat box, start writing down just the few, how do you think the patient is going to present to you if she has hyperprolactinemia? Now, you don't know that her prolactin levels are high, but there are certain clinical features with which you can find out that she is having hyperprolactinemia, one of which, of course, all of you know and no marks for that. But apart from that, I want to see how, thoughtful your mind goes. Let me know quickly the clinical features with which a patient with hyperprolactinemia is going to present to you. Everyone in the chat room, everyone start writing down. Everybody who's attending the class, please make sure that you go back to the main group and join the pinned message. Just click on the pinned message and join the chat room. Okay, so one, if primary amenorrhea could be yes, one reason, yes, one clinical presentation, I agree. Breast secretion is like I said, that is the most obvious. Amenorrhea, okay. One of them, yes, primary amenorrhea, right? Irregular menstruation, yes, good enough, fair enough, agreed. Visual defects, okay, fine, agreed. Galactoria, infertility, yes, infertility, very good. What else? Okay, and then I'll begin with my list, okay? So clinical presentation of hyperprolactinemia. Now you remember that even if you write down these points, you will get marks, okay? But since it's a 5-mark question, at least is what I'm expecting from the question paper. Again, these are all recall questions. I do not know the exact questions, right? So I'll be writing down a couple of answers which are sufficient for a 5-mark question. And you have to probably just 1 or 2 lines about each of these points that you said. So clinical presentation of hyperprolactinemia. Basically, there's an effect of the hypothalamic pituitary gonadal axis, right? So one of these things it's going to present as oligomenorrhea or amenorrhea as the hallmark feature. See, oligomenorrhea, amenorrhea, like so many of my intelligence students said, is the hallmark feature, correct? Then, of course, breast secretions and fertility. So these things, now what I've done is that, what do you want to write? Why would there be a menstrual irregularity? Probably that's what you're going to write down, right? So this occurs because of elevated prolactin. It inhibits the GnRH and leads to reduced LH and reduced FSH levels, and they in turn suppress the ovulation. So why does it happen actually? So you have so much of prolactin that it's actually reducing the, the secretion of GnRH, and then all of a sudden, obviously because of the suppression of GnRH, LH, FSH both get suppressed, ovulation hota nahi, and then you have menstrual irregularities. Same thing happens because same reason is for infertility. And ovulation is the reason for infertility, correct? Again, galactoria, very important. This could be the third point. Okay. Now, in case of galactoria, why does it happen? Obviously, because there is more of prolactin. Prolactin causes galactoria. Simple as that. Decreased libido and sexual dysfunction could be one reason. One clinical feature. And then you have, of course, breast tenderness, hirsutism, all these things. So I think most of which we'd already expected, we've already covered. And if you write down 1, 1, 2, 2 lines, why does it happen? Maybe that's going to help you, and that's enough. Now, coming to diagnosis and management of a case of hyperprolactinoma. Now, remember that whenever I talk about hyperprolactinoma, I'm talking either in terms of microadenoma or macroadenoma, both of which are different. And whenever I talk about management of a case, you start from diagnosis, and diagnosis means history, examination, investigation. You cannot miss these things. So here I start with medical history and physical examination. So the detailed medical history that you just gave me, that's also all going to be included here. And the investigations is of course going to include the breast secretions, any lump, any other reason for a breast secretion, and then of course maybe if he's having field defects, then probably a field charting, correct? Visual field testing. See, breast examination for galactoria, visual field testing. Amongst the lab investigations, you want to get at least a serum prolactin level. So tell me one thing, guys. When you see a patient with prolactin level increased, don't you guys all see this thing that what is the level of prolactin hormone in her? Because I've seen patients being treated for 56 nanogram per ml, 76 nanogram per ml. So we say it's only after 200 plus, then they're suggestive of prolactinoma. Somewhere I've seen written 500 plus. Don't get serious until it becomes 500 plus, but 200 seems decent enough. So you can give bromocryptine to patients with 76 and all, but usually that is not suggestive of any prolactinoma as such. Maybe when you get repeated again, it's either the same or it has dwindled down. Then you do go for a thyroid test, pregnancy test, if it's amenorrhea, sometimes even with oligomenorrhea, liver and kidney function test. They can cause secondary hyperprolactinemia. So always go for LFTs and KFTs, correct? Imaging studies are the modality of choice, MRI being the more preferred one. Whenever you do something with the brain, you usually prefer an MRI. Microprolactinoma is less than 10 millimeters. You know what is the size of a 10 millimeter? Just imagine, more than 10 millimeter becomes macroprolactinoma, and less than 10 millimeter becomes microprolactinoma. What is what is 10 millimeters? Do you know that? Very, very small. Okay, that almost a dot. So microprolactinoma is that, and macro means more than that, more than 10 millimeters, right? And of course, you have to rule out the other causes. What are the other causes of hyperprolactinemia? Did they ask you about the causes? Did they? They never asked you the causes. But what are the causes? Certain drugs are responsible for causing hyperprolactinemia, and they're given over here. See, antipsychotics, antidepressants, antiemetics. You must have heard and mentioned a lot of them. Many patients, when they come to you, they're already on antipsychotic medications. So ask them this. This is very important. Usually antipsychotics, less with antiemetics and antidepressants, yes. So mostly the patients, they come to you with a previous history of depression. So they're already on antidepressants. So psychosis, and they're already on antipsychotics. Antiemetics, not so much, but yes, antipsychotics and antidepressants definitely they do cause. So mostly this. Now, what will you do to manage it? You've done the diagnosis part, now you're managing it. So for example, you do actually find a microprolactinoma, then you manage it with medical management. And if you see a macroprolactinoma, which is not responding to medicine, then you go in for a surgery, right? So medical management, you have dopamine agonist. What have you heard? Isn't it? You've heard the medical management first line as dopamine agonist. That means all your bromocryptines and all these are all your dopamine agonists, right? Cabergoline, preferred treatment due to its higher efficacy and better tolerability. What are you guys using more, bromocryptine or cabergoline? When you have hyperprolactinemia, what are my students using? Come on, guys, quickly answer me. You using brom or you're using cabergoline? Yeah, I've been giving cabergoline, as it's mostly mentioned in most of the books. The preferred treatment due to its higher efficacy, better tolerability. It's administered once or twice weekly, associated with fewer side effects. It's even good for compliance, right? Which is why mostly I use that. Of course, the alternative is bromocryptine. And again, it's little more side effects compared to cabergoline. That's the reason why mostly people choose cabergoline as compared to bromocryptine. And how do you monitor? You do a 4 to 6 weekly check after starting the treatment. Restoration of fertility. Once prolactin levels are normalized, ovulation often resumes, and many women can conceive naturally. So then see, this was actually the medical management, correct? Then you have a surgical management, and there is a transsphenoidal surgery which is done to finally just resect it out. If it's not being managed with even a certain macroprolactinoma, the first thing you do is give a medical management. But if it's already too big, then you directly go for transsphenoidal surgery. So this thing surgery is generally more effective for macroprolactinoma than micro. This should be the thing. I'll just change it because otherwise you'll get confused later on. Surgery is more effective Recurrence is possible. That is definitely there. So surgery you will choose mostly for macro, then microprolactinomas, and recurrence is possible though. But anyways, you will still keep giving her the medical management later on, just in case there is a recurrence. And radiation therapy is mostly reserved for cases of medical and surgical treatments fail. So first of all is definitely medical management. Second is transperineal surgical management, and then third is radiotherapy. If it is not, shrinking down with medicine and surgical treatment is also failed, there is recurrence. Then you better go for radiotherapy. But that's like, how many cases have you seen? Okay. And as far as pregnancy considerations are concerned, women desiring pregnancy, treatment with dopamine agonists typically continued until conception. Okay. Bromkriptine is more safe as compared to cabergoline, but I would not suggest either. Yes, after conception, dopamine agonists are discontinued. Okay, here. So, but we do close monitoring throughout pregnancy with serum prolactin levels, and if necessary, MRI scans are also recommended during pregnancy. And then, of course, follow-up. Nobody's asking you, but yes, long-term follow-up is definitely there. Every 6 to 12 monthly, you are doing prolactin testing and periodic MRI imaging, correct? And there's a long-term management. While dopamine agonists are effective in controlling hyperprolactinemia and tumor size, they often need to be continued for many years or even lifelong to prevent recurrence. Okay. Now, I'm going to talk about causes of secondary infertility. Can you guys quickly start enlisting the causes for secondary infertility? Yes. I want to hear this from my students because I'm very, very sure they know and they can tell me. Yes, secondary infertility, guys. Salma, are you trying about Turner mosaic? You're talking about secondary infertility? That means she was pregnant once? Turner mosaic usually has very weird presentations. It could be secondary amenorrhea, it could be secondary infertility. I'll accept it. Let's talk about the easier one first. So all those things which can be acquired, like for example, fibroids or endometriosis or adenomyosis or blocked tubes or PID, these are all things which can happen over time. Okay, maybe she had a pregnancy before, now she cannot have it because she's developed so much of infection, endometriosis or any other structural abnormality. So secondary infertility usually comes, if it's a female factor, mostly because of this. PCOS, yes, PCOS, PID, endometriosis. I see everything I've written down. Acquired conditions like Asherman syndrome. Yes, absolutely. Age, very, very important. Age factor for secondary infertility. Absolutely. Okay, agreed. Shihan, okay, agreed. What about male factors? Can anyone quickly tell me? Why can't semen parameters go haywire with age? Varicocele can be done. And varicocele, just an isolated varicocele in a male, we will not bother. But a male who has a varicocele and has abnormal semen parameters, you are bothered. You might want to operate upon this varicocele. Okay. Then couple specific factors like maybe a lifestyle change or more stress, living apart. Okay. Age, both the partner's age is increasing. Timing, frequency of intercourse. Yeah, like I said, living apart. And I'm not going to talk about immunological infertility because that's not there. And then, of course, you have combined factors.